Hello everyone, today we are going to talk about Polycystic Ovarian Syndrome. So what is PCOS and what are the characteristics of PCOS? PCOS is one of the most common endocrine disorder in women. It is characterized by hyperandrogenism, which is primarily manifest as hirsutism, acne and virilization. What is virilization? Virilization is appearance of male secondary sexual characteristics like voice deepening, hirsutism, male pattern, hair loss, and increased muscle mass. So we also have other characteristics in PCOS like oligoovulation or anovulation or presence of polycystic ovaries. These are some characteristics which we found in PCOS. First of all, hyperandrogenism, oligoovulation, anovulation, and presence of polycystic ovaries. Now, how we diagnose PCOS? Diagnosis involves complete history and physical examination to evaluate for ovulatory dysfunction and clinical signs of hyperandrogenism. The next step is lab test. Lab tests are performed to confirm biochemical and hyperandrogenism and exclude other conditions with a potentially similar clinical picture like CAH, for example congenital adrenal hyperplasia. We can also use ultrasonography, but in the absence of ovulatory dysfunction and hyperandrogenism. We do ultrasonography to identify cystic follicles and assess ovarian volume. Now, how we manage PCOS? For the management, first step is lifestyle modification and a specific treatment. These are some steps which is recommended for all patients of PCOS. First of all, they should encourage exercise and healthy eating, calorie restriction, and also consider behavioral strategies and modification such as for example setting goals, eating more slowly, and here our target BMI is less than 25 kg per meter square, and they should also screen for comorbidities and we should provide them a specific treatment. In additional therapeutic interventions, these are based on their reproductive goals and comorbidities and also individual risk factors. Now we have two group of patients. First, the patient not planning to conceive, and second, the patient planning to conceive. For patients who do not wish to conceive, our therapeutic goal is to control menstrual irregularities and hyperandrogenism and also treat comorbidities and improve quality of life. So, first line treatment for hyperandrogenism and menstrual cycle abnormalities, we use combined oral contraceptives. These combined oral contraceptives has some additional benefits as well. For example, decrease menstrual bleeding, decrease acne, and decrease endometrial hyperplasia. Also, these combined oral contraceptive is used for the treatment of hirsutism. Our second line treatment is metformin. Metformin is used in patient who is unable to take or tolerate combined oral contraceptive. Metformin improves menstrual irregularities, metabolic outcomes, and weight, especially with lifestyle modification. Our third line drug is anti-androgens, which has a controversial role. Now our second group is patients planning to conceive. Here our goal is management of comorbidities. For example, weight loss for overweight or obese patients and also induction of ovulation. Here we use first line therapy for ovulation induction is letrozole. It improves pregnancy, also live birth rate in patient with anovulatory infertility with no other cause. We can also use alternative to letrozole, clomiphene. It is also may be preferred over metformin monotherapy in obese women with anovulatory infertility. So thank you so much. If you like my video, do subscribe.